Good evening, everyone. Welcome. Thank you so much for joining us for this virtual UMiami Health Talk, a highly anticipated topic tonight called Disruptors of the Obesity Epidemic. I'm health journalist Ileana Bravo, and I'll be your moderator for this evening's talk presented by UHealth, the University of Miami Health System. As South Florida's only academic-based health system, UHealth combines exceptional patient care, breakthrough research, and novel education to create an innovative approach to healthcare. Patients can participate in clinical trials and benefit from the latest discoveries that are fast-tracked from the laboratory to the bedside, with treatments that are tailored to each patient. So if you're interested in exploring medical weight loss options, we invite you to call our anti-obesity helpline at the number on your screen, 786-654-4829. And we want you to know that our specialists will support your journey towards a healthier lifestyle. Well, tonight we're privileged to hear from a panel of esteemed medical, business, and pharmaceutical experts. They'll delve into various topics related to obesity disruptors, including the far-reaching societal and economic impacts of the epidemic, challenges pertaining to access to medication and the extended effects of GLP-1 drugs, nuances of physician bias against anti-obesity prescriptions, the impact of bariatric surgery on employment and psychological well-being, societal perceptions surrounding surgical interventions, the reluctance surrounding insurance coverage for obesity treatment, incretin therapy and its relation to addictive behaviors, and finally, future developments in this transformative field. Tonight, it is our goal to educate, and there are hundreds of you joining us tonight, so we know how important this topic is. So at the end of our experts' presentations, you're going to have the opportunity to pose your own questions in our Q&A session. We're going to move it along as fast as we can to get as many in as we can. You'll know how to use the Q&A feature. It's at the bottom of your Zoom screen. Take a moment to locate it, and we'll prep them for our experts. So let's begin with our first speaker before I introduce our full panel. Dr. Ernesto Bernal Mizrahi, a professor of medicine and the chief of the Division of Endocrinology, Diabetes, and Metabolism at the Miller School of Medicine. Over the last 15 years, his research has focused on novel pharmacological agents for the treatment and cure of type 1 and type 2 diabetes. Let's welcome Dr. Bernal Mizrahi, and please make sure your mic's open, Doctor.
I need to be able to share the screen here. Thank you, Ileana. Perfect. Thank you. So what I will try to do during the next few minutes is to provide some basic information with the idea of setting up the stage for the discussion of our outstanding group of panelists. And the first thing that I would like to address is how we define obesity. Overweight and obesity are defined as excessive fat accumulation that presents a risk to health. And we use the body mass index to diagnose obesity. And this BMI is a calculation that helps determine a healthy body weight based on your height. And you can see a formula here. Now, as you can see below, the healthy weight is defined as body weights that are between 18.5 and 25. Overweight is defined with BMI between 25 and 29.9. And obesity is defined as in individuals with BMIs between 30 and 39.9. With severe obesity with BMIs above 40 of BMI. Now, sorry, here. So what is the prevalence of obesity? As you can see in this slide, this is the prevalence of obesity and severe obesity from 1999 to 2018. And as you can see, the prevalence of obesity goes steadily increase from 30.5 to 42.4, as you can see here in the graph. And this doesn't include the overweight population. If we combine obesity with the overweight population, we can reach levels that are around the 70%. And then below you can see in green that the prevalence of severe obesity has doubled between 1999 and 2018. And I'm not including here the different states, the prevalence of obesity in different states, because I think most people are aware of that. But in general, the prevalence is very high across the country. Now, when we drill down into the race and of obesity as a factor, what you can see here on the left is that the group with the highest prevalence of obesity is the non-Hispanic Black, and the group with less obesity is the non-Hispanic Asian. Now, when we divide this data in between men and women, what you can see is that the non-Hispanic Black is the non-Hispanic female Black are the groups that are more affected by obesity in the US. Now, this high prevalence of obesity is associated with a huge economic impact. And as you can see, there is a $480 billion dollars in direct costs, and this includes not only the inpatient, the outpatient, and the prescription medications. There is a $1.2 trillion in loss of productivity, and this is by absenteeism, loss of work, disability, and workers' compensation. And when we look at the cost by obesity and all the comorbidities that achieve up to $1.72 trillion. So this is a huge, huge economical impact for the society. Now, this is a very simplistic way to show how weight is regulated. Weight is regulated by a balance between energy intake and energy expenditure. And energy intake includes hunger and satiety, and energy expenditure includes activity and metabolic rate. And when calories in equals calories out, and there is a balance between the two, the weight is stable. As opposed when there is an increase in the energy intake, where calories in are higher than the calories out, that's where weight gain occurs. And finally, when increase in energy expenditure is higher than energy intake, then calories in are less than calories out, and that's when weight loss occurs. Now, this was a very simplistic explanation of weight regulation, but this is more complex, and there are some specific areas of the brain that are involved in regulation of energy balance, and these areas of the brain are receive signals by the environment, and also hedonic signals, socioeconomic signals, and also signals from different organs, including the pancreas and the gut. And we cannot also ignore the contribution of some medications with weight gain, and also a contribution of genetics. And we had today an outstanding talk by Stephen O'Reilly, where he describes some of the genetic basis of obesity. Now, obesity is also associated with many comorbidities. The most common that we all know is prediabetes and diabetes, but it's also associated with coronary artery disease, cancer, sleep apnea, and non-alcoholic fatty liver disease, among others. In this slide, I provide a summary, a very broad summary of obesity therapy. And I like to start with saying that lifestyle modification should be an integral component of all therapies, and this includes diet and exercise. And usually this is recommended as the main therapy for individuals with BMIs between 25 and 30. Now, when we look at medications are usually indicated in patients or individuals with BMIs that are above 30 or BMI between 27 and 29 with weight-related comorbidities. I show here some of the medications that are used for obesity, but I will expand a little bit later on the role and the use of GLP-1 and GIP receptor agonists, which are medications that have very potent weight loss effects. And finally, surgery is indicated in individuals that with BMIs above 35 or individuals that have a BMI between 30 and 34.9 with comorbidities like type 2 diabetes. And I'm not going to explain or mention anything about surgery because Dr. Nestor de la Cruz will talk about this later. Now, I mentioned about the GLP-1 and GIP hormones or agonists in the previous slide, and I just want to explain a little bit more about these two hormones. These two hormones are produced and secreted by the gut, and they are called incretins because they are secreted when there is food in the intestine, and the secretion of these hormones will facilitate the secretion of insulin in the presence of high glucose. Now, GLP-1 binds to the receptors in different organs to decrease satiety in the brain, food intake, increase satiety, decrease food intake, also decrease gastric emptying, increase insulin secretion, and decrease fat content. In contrast, GIP also has some effects in the brain with decreasing food intake, body weight, also increasing insulin secretion, and increasing insulin sensitivity. Now, what is interesting about these hormones is that the pharmaceutical companies have used this mechanism and these hormones to generate medications that will act or are called GLP-1 or GIP analogs. And these medications, as I mentioned, are one of the major therapies that we have for type 2 diabetes and obesity currently. Now, in this slide, what I wanted to summarize is the effectiveness of these medications as a single or a combination of different pharmaceutical agents. As you can see in orange, the weight loss effects of the GLP-1 analogs that you can achieve by different administration via oral or sub-Q. You can achieve weight losses that are up to 17%. Now, when we look at agonists that are dual agonists of GLP-1 and GIP in the dark blue, we can achieve weight loss effects that are up to 22.5%. And now there are some other dual or triple agonists that are in clinical trials, and I just like to mention about the triple agonist that acts on the GLP-1, GIP, and glucagon receptor. And this medication has shown significant weight reductions that are up to 24.2%. But like all the medications, these medications are also associated with some side effects that actually lead to discontinuation of therapy in some patients, and those are mainly gastrointestinal symptoms that include nausea, diarrhea, vomiting, constipation, and abdominal pain. Now, some of the contraindication of these medications are patients that have genetic forms of thyroid cancer, like medullary thyroid carcinoma or multiple endocrine neoplasia, but these are very rare forms of thyroid cancer. And with this, I will stop here, and I will turn this over to Ileana. Thank you.
Thank you so much, Doctor. It was as clear and succinct as possible for the layman to understand exactly what we're going to be talking about today. So let's now introduce the rest of our panel. Dr. Nestor de la Cruz Munoz, a professor of clinical surgery and chief of the Division of Laparoendoscopic and Bariatric Surgery at the Miller School of Medicine. He's also co-director of the Center of Excellence for Laparoscopic and Minimally Invasive Surgery and medical director of bariatric surgery at the Hospital. Dr. de la Cruz Munoz has received numerous awards throughout his career and has given many presentations nationally and internationally in the field of bariatric and general surgery. We move on to Dr. Emma Boswell-Dean, PhD and Assistant Professor of Health Management and Policy at the Miami Herbert Business School at the University of Miami. She's a health economist whose research encompasses issues related to pharmaceutical policy and pricing and the relationship between poverty and health. She earned her PhD in Managerial Science and Applied Economics from the Wharton School of the University of Pennsylvania. Dr. Samuel Klein, MD, is the William H. Danforth Professor of Medicine, Director of the Center for Human Nutrition, Director of the Center for Applied Research Sciences, and Chief of the Division of Nutritional Science and Obesity Medicine at Washington University School of Medicine. Dr. Klein's research activities are focused on understanding the mechanisms responsible for the heterogeneity in metabolic dysfunction associated with obesity and the therapeutic effects of weight loss. Dr. Anthony Fabbricatori is a licensed psychologist with experience in both academic and industry settings. He's currently medical director in medical affairs and obesity at Novo Nordisk. His career began at the Center for Weight and Eating Disorders at the University of Pennsylvania Perelman School of Medicine, where, as assistant professor of psychology and psychiatry, his clinical and research efforts addressed various aspects of obesity assessment and management. And finally, Dr. Brian Finnan, PhD, a distinguished scholar who earned his PhD in biochemistry from Indiana University. Throughout his career, Dr. Finnan has focused his research on the field of obesity therapeutics, notably in the discovery of first-generation GLP-1, GIP, and glucagon multi-agonist. Since 2022, Dr. Finnan has dedicated his efforts exclusively to advancing the frontier of obesity research. Okay, so all those wonderful, esteemed colleagues who are joining us tonight, it's time so we can kick off the panel discussion. And in the meantime, you remember to add your own questions in the Q&A box so that we can take care of those as we go. All right, I'll direct the first question to Dr. Emma Boswell-Dean and Dr. Fabbricatori. Here it is. If we successfully address the obesity epidemic, how would it transform societal norms and structures? Whoever wants to begin.
You want to start, Emma, or should I?
Either way works for me.
Well,
Go ahead.
I'll just talk about as Dr. Bernal Mizrachi mentioned, that this is a disease that affects over 40% of the population. So if we're successfully able to address or treat an epidemic of that size, frankly, it changes everything. And it's hard to overstate how just really transformational that would be. He also talked about the economic impact of obesity, which is much more in your shop than mine, Dr. Dean. But if obesity were not a part of the picture, there would be certainly a great deal more resource to address other health conditions. And I think you could easily imagine that many of those other health conditions would be reduced in prevalence and intensity because so many of them are fed by obesity. One thing also I want to mention about, again, if the obesity epidemic were addressed successfully, you would see broadly closing of health inequity gaps. Because again, as Dr. Bernal Mizrachi mentioned, the prevalence of obesity is much higher in African Americans and Hispanic Americans than the white and Asian Americans. And generally those groups have lower access to healthcare broadly and exposed to a number of social determinants of poor health. So if obesity were to be eliminated, that would do a lot to close racial and economic gaps in health.
Yeah, absolutely. And just to add a bit to that, I think part of solving the obesity epidemic and addressing it is closing some of those societal gaps and economic gaps to begin with. So much of the rise in obesity is caused by, we also have a lot of people who don't have access to healthy food that's affordable, who live in food deserts. And so it has to be this bi-directional relationship where we're working on those underlying social issues. And one of the reasons it's so hard to determine the economic impact of obesity is because it is so correlated with these other economic factors and social factors that can also separately affect people's health and well-being. But yes, absolutely agree with everything that was just said as well. Obesity affects so much of the population. Being able to close that gap, it has impacts that are enormous. You know, we've seen, for instance, even in the military, only 2 of 5 young adults are weight eligible and adequately active to even join the military now. Well, it's a much bigger problem in the military. We even see, you know, FedEx having trouble finding drivers who can walk quickly enough to the front door to drop off packages and lift packages. So being able to solve this solves a lot of other bigger picture economic issues that we don't even think about as necessarily being health issues.
All right, let's transition over to Samuel Klein and Brian Finnan. This question I'll pose is, besides weight loss, these wonder drugs, these GLP-1 drugs, what effects do they have on cardiovascular, on renal health, anti-inflammatory properties, and even potential treatments for neurodegenerative diseases?
Brian, you want to go or you want me to go?
Happy to go, Samuel. Yeah, so there's a multitude of benefits that we are seeing with GLP-1 based therapies, both in type 2 diabetic patients, but also in patients living with obesity as well. You know, going beyond the weight loss and the lowering of blood glucose, I think the most notable thing that we are seeing with these treatments is an actual improvement in cardiovascular disease. So much so, a recent trial readout showing a 20% reduction in a composite on cardiovascular disease in patients living with obesity and established cardiovascular disease. And I think that's a really a groundbreaking trial because it is not just showing the improvement of quality of life, quantity of life in those patients, but we also hope that a trial like that will start to change on payer perspectives as you actually see hard outcomes of benefits on weight loss medications. But beyond the cardiovascular disease, there are proven benefits of GLP-1 based compounds in improving chronic kidney disease in type 2 diabetic patients. We don't know exactly how that will translate into non-diabetic obese patients living with chronic kidney disease, but clinical trials will read out in the near future. But we've also seen improvements in other cardiovascular endpoints, most notably an improvement in heart failure, particularly patients with a preserved ejection fraction. GLP-1 based agonists and semaglutide just showed an improvement in a clinical trial there. So it's improving multiple aspects of cardiovascular disease. And I think I'll pause right there and pass the ball over to Dr. Klein to see if he wants to add any more to the CV benefits, or I can also speak to the other comorbidities.
No, I'll just add some brief comments. I agree completely with everything that Brian said. I think the question underscores the point that obesity has adverse effects on nearly every organ system in the body, and weight loss will help either prevent getting diseases or ameliorate active concurrent obesity-related diseases. And so the therapeutic goals of treating patients is really not weight loss, but to improve their medical health, as well as their, as Brian mentioned, their physical function and quality of life. And so we shouldn't target a certain weight loss. We should target an improvement in overall health of the patient who's taking medications or any kind of obesity therapy, and see what that does to their overall metabolic, cardiometabolic, renal, cancer risk, Alzheimer's disease risk, etc. But in addition to that, their ability to function and have an improved quality of life.
So what you're saying is, I'm sorry, what we're hearing is even on Alzheimer's, so on neurodegenerative diseases, these drugs can help because obesity is something that leads or can contribute to dementia?
Yeah, so I think, Alzheimer's, some people call it type 3 diabetes. And so there is a link between insulin resistance, diabetes, and obesity and Alzheimer's disease. Now, when you develop Alzheimer's, you stop eating. So it is a weight loss therapy at the same time, but the damage to your brain has already been done. And so potentially reducing body weight and improving metabolic health will reduce the risk of Alzheimer's disease, but that has not been proven.
Absolutely, yeah, it's not been proven yet. There's cohort studies demonstrating weight loss effects through various interventions, can lead to benefit, but it needs to be substantiated. There is ongoing clinical trial of semaglutide in patients with early Alzheimer's, and we're eagerly awaiting the readouts from that. There's historical data of the first generation GLP-1 exenatide showing a benefit in, I think it was mid-stage Parkinson's disease. So there's breadcrumbs of evidence that is suggestive that GLP-1 based treatments can be beneficial. The thing that we don't know yet is how much is coming from the weight loss per se versus how much could be an on-target effect of the GLP-1 itself.
Yeah.
There is another on-target effect that's a side effect of the drug, and that's the decreased alcohol abuse potentially, and also drug abuse. So it's being tested right now aggressively in reducing, addictive behaviors.
Sorry.
The last thing I want to address, because I saw there was a Q&A and I can't type and talk at the same time. There's questions about osteoarthritis and arthritis. And again, that is a known complication of obesity, of an increased prevalence of arthritis, particularly knee osteoarthritis. And again, there's breadcrumbs of evidence, both preclinically and now some data trickling out from clinical trials, that there is an improvement of quality of life and arthritis endpoints with semaglutide treatment. But again, that needs to be further substantiated and proven.
Yeah.
And
Besides
Sam,
the obvious, I'm sorry, Dr.
sorry, Sam and Brian, could you comment about some of the mechanisms of how these medications can, improve the specific organs besides the weight loss, as you said? Can you speculate about, inflammation and other type of mechanisms that?
So, that's a tough question. We in the research field are really trying to dive in to better understand the direct effects of GLP-1s on these other end organs, you can say. But we do know across trials, across GLP-1 based medications, there is a decrease in some inflammatory markers, most notably CRP, across trials. And how much of that is meeting this effect, we don't know. Again, it needs to be substantiated, because right now it is more just, you could say, either more anecdotal evidence, or it's just not been linked to the precise mechanism. But I don't think that there's going to be one mechanism that is driving this. It's going to be a composite of the multiple ways that GLP-1 is working. What we have learned is that these drugs with GLP-1 really work on multi-parameters and on both direct and indirect effects in organs. And we just need to tease all that out, now that we have these effective medicines and we can test them in a clinical setting.
Yeah, so Ernesto, your question is a Nobel laureate winning question, if it could be answered. But what's just amazing is adipose tissue is an incredible organ. When it expands when you eat more calories when you eat, and it shrinks when you don't eat. And so it's amazing that this organ can just change its shape, based on energy balance. What we really don't understand is why, when you shrink it, do things get better. There's a lot of dogma out there, especially about inflammation, other things that are just unproven. What are the signals when you shrink your adipose tissue? What's the actual signal that goes to other organs to make them better? We know what happens to adipose tissue, but we don't know how it communicates with other organs. You probably do, but you haven't told anyone as yet.
This is like a master class tonight. We are so privileged to be getting this kind of, deep dive into this topic. Let's bring Dr. Ernesto de la Cruz into the conversation too, and along the rest of you. Doctor, what barriers, for instance, such as cost, and hinder access to medications and to even surgical interventions for obesity management, which is right up your alley?
Well, good evening. Actually, I'm just glad not to have to answer Dr. Klein's question, because that was that was the killer. Anyway, there are definitely many hindrances to bariatric surgery, as well as medical treatment of obesity, and the biggest one is insurance coverage. Insurance companies have never covered obesity management, and they continue routinely not to cover it, and thus it is a costly, like anything else in medicine, it is costly if you have to self-pay, and especially if you're already paying for insurance and not getting any benefit from it, it seems double costly. Number two is a lack of appropriate physician referrals. Physicians don't appropriately treat obesity like they should. We've seen the charts and the graphs of how to deal with these patients, but yet they don't get referred out like they should be referred out to the medical weight loss specialist or the surgical weight loss specialist. They just get told to try to lose weight and come back. And too many of them just keep experiencing failure that way and are embarrassed to push it any farther because their doctor hasn't done anything else. And then the third one is the social stigma against obesity and its treatment options. For the last 20 years, I've been having to deal with the social stigma against bariatric surgery as a bariatric surgeon. But I stood there in shock in the last couple of years as the American Association of Pediatrics came out with new obesity treatment guidelines, and it got panned by the public and by even pediatricians because they felt they were too aggressive, and they were perfectly evidence-driven. And then now the obesity drugs are really coming out. They're having great benefits. And what happens? They get panned in the media and panned by the public for the same things, and even panned by physicians for the same things. And all it leads me back to is obesity has a big stigma against it, and nobody likes the treatment of obesity. And I think partly it's because 75% of Americans are overweight. Most everybody would like to lose some weight. And I think everyone gets jealous when other people find some success.
Any other panelists want to weigh in on this topic?
Sure, I'll add. And of course, cost and access, cost is a major concern, and we can't ignore that. I want to just sort of expand maybe on this idea of stigma and bias. That like a lot of stigma, I think it's in part based on a lack of understanding. I think the broad understanding of what obesity is quite poor, actually, and this is true not just in the general public. It's true among healthcare professionals as well. Many doctors still will think of obesity as something that is the patient's fault, something that the patient can solve through cognitive control, through willpower. And that really ignores the last, 20, 30 years of science, if not more, showing that, as Dr. Klein said, fat tissue is not an inert storage organ, right? It communicates with the rest of the body. Obesity is an endocrine disease. It is the fact that obesity is a disease, that it's chronic, that it's progressive, that you should not expect that you will have a long-term effect if you stop treating, just like you wouldn't expect a long-term outcome for diabetes if you stop taking a diabetes medication. So there's this broad lack of understanding, which feeds negative assumptions, which feeds the lack of referrals, as Dr. De La Cruz said. It's really a problem that hopefully can be addressed, at least in part, with education on the level of the public, but also in medical and other professional schools.
I wonder, how is the pharmaceutical industry being affected with the boom in these wonder drugs, and yet now the decreased use of the other medications that were used for comorbidities related to obesity?
I guess I can only speak for one company, the one that I work for. By way of disclosure, this was mentioned in the intro. I work for Novo Nordisk, which produces one of the GLP-1 receptor agonists. Obviously, it's been a boon to our company, but I think largely on an industry level, what you see is more players getting into the game in terms of understanding that obesity actually is a medical condition and can be treated medically. And that is leading to just major advances in the science around obesity and the tools that will be at clinicians' disposal and patients' disposal to manage that obesity through different pathways.
Someone is printing something. Hang on a second. I think that just passed. Go ahead.
Yeah, I can comment as well. Also, I guess disclosure, former employee of Novo Nordisk, soon to be employee of Eli Lilly. So living that duopoly right now. The goal that we see with all of these next generation medications that work on the full metabolic syndrome is actually you can start to peel off other medications. So that is the goal that we also have with these currently approved first generation, second generation medicines, is that you can actually start to reduce the burden of pharmacology on that. But that needs to, again, there's not been extensive studies into what type of medications can be peeled off, et cetera. But real world evidence is what we'll lean on for that.
And along those lines, let's talk about cost. I mean, these medications are expensive. There's also apparently shortages with those who really need them. For those who are taking it in Hollywood, let's be honest, right? It's become the sexy drug for someone who's maybe 20 pounds overweight, et cetera. So how are we mitigating all of this?
I think more players in the game, more manufacturers is going to help. To be honest with you, it's we did, again, speaking for my own company, we did have some difficulties with manufacturing at the outset. Now it's much more an issue of demand. It's just too great. We're talking, as we said earlier, we're talking about 40% of the adults in the country meeting the BMI definition for obesity. And that is just too much for any one company or two companies or several companies to be able to produce enough drug for. And these are, they're fairly, I'm sorry, there's a printer going on in the background. I'm going to mute myself and let Brian take over.
Yeah, the demand is growing every day, you can say, and that's because these medicines are effective. But one thing that is alarming is that even just on World Obesity Day last week, the WHO said that 1 billion people worldwide are living with obesity or overweight. And in reality, between the medications that are out there for anti-obesity therapies, we're reaching, on a good day, 1% of those patients. And the demand right now is sky high. Now, also to address the kind of the elephant in the room, you said it's the Hollywood, the trendy drug. And it's also very clear that, Ozempic and Mounjaro, those are approved for type 2 diabetes. Now, Zepbound and Wegovy are approved for obesity. Yes, it's the same drug, and in some case, in semaglutide case, a higher dose for obesity. But I think it's very clear that all of us in the pharmaceutical industry are making sure that these drugs are being used by the right patients and are prescribed to the right patients based on the indication.
I wonder if I could ask Brian and Anthony a question. So there's reports that most people who start GLP-1 based therapy stop them within a year, even though they've lost weight, and it's not from side effects, because those side effects are pretty much gone, after the first few months. Why is it? Is it the cost? Is it they don't want to feel that they're sick by taking medication? Do you have any insight as to why people stop taking the drug despite a successful effect?
I don't have data-based insight. I'll say that. But I think the things that you mentioned are certainly factors. Cost is one. People's insurances change all the time, and that's another. That's a factor. The inability to keep supply up with demand is another. But I think and I kind of alluded to this earlier. The belief that obesity is something that's acute, something that you can treat, and then kind of use a medication as a kickstart or get you to a certain weight, and then you can quote do it on your own after that. It ignores some of the physiology that we know, right? That maybe the public doesn't fully know yet. And I think that's one message I think that I would love those listening to understand. If you are on a medication, regardless of what it is, for obesity management, for weight management, and you stop that medication, it is not your fault if you regain the weight. It is your physiology, it is your body doing everything it can to replenish those lost fat stores. And that's just the way we are set up as humans. Even if we have extra fat stores, our body doesn't like to lose them. And through suppressing our metabolic rate, through increasing our hunger hormones, suppressing our satiety hormones, our body will do what it can to try to replenish those lost fat stores. So just like you stop taking an antihypertensive, your blood pressure goes up. you stop taking an anti-obesity medication, your weight will go back up.
So at this point, as far as the science has gone, and we know that it's developing by the nanosecond, this would be a drug for obesity that would be forever. It is not something to take now and stop later and back and forth, right?
There's there's discussion of what's called a set point, body weight or body fat set point, where there's this is theoretical. That hasn't been established, but the idea is that there may be, after establishing a new baseline for your body weight and your body fat, that perhaps that becomes your new normal, and you may no longer need the therapy. Now, we don't know, one, if that happens, and if it does, after how long? How long do you need to have that baseline established? And I'm sure Dr. Klein probably has a lot more to say, a lot more insight into that, if not others on the call.
Yeah. And Dr. Dela Cruz, if we could go back to the shaming aspect of someone who needs bariatric surgery, and the fact that perhaps their own personal physicians don't refer them out when in fact they might be perfect candidates. Talk about those biases and why we're still where we are so many decades later.
It's difficult. I mean, I think because the public perception hasn't changed, and even physician perception hasn't changed over time. Luckily, in bariatric surgery now, we have a lot of long-term data for outcomes and for improvements in metabolic disease. And now not only have we gotten to the point that we have data that shows that bariatric surgery causes weight loss. We have data that shows that this long-term weight loss helps get rid of or improve a lot of the metabolic diseases that come with obesity, like high blood pressure, diabetes, and sleep apnea. And now we're moving on to the next level, which is looking at long-term data showing that this is decreasing the long-term complications from those medical problems that the patients had. So we're seeing less strokes, less heart attacks, less amputations from diabetes, a lot less problems by getting rid of it. You would think that the docs would be on board, and every time you see a patient who is suffering from severe obesity, they send them over. They really don't. And when I see a lot of patients and I review their PCP notes, they may mention weight loss once or twice, but very rarely are they ever talking to the patient about bariatric surgery, which is a shame. Now, that being said, we're advanced over where we were 15 years ago, where many docs would tell their patients, if you had surgery, you're not going to be able to see me in follow-up. So I'm hoping that the medicines don't have such a severe effect. I don't think so. I think that the medical practitioners are more willing to prescribe the medicines and more willing to see it. But I'm still seeing a lot of questions. That every little thing that you see on TV about a complication from the drugs, the docs are pushing it. That's always their first questions when they sit around and talk about them.
Yeah. And I'd like to bring in Dr. Boswell Dean also to talk about the insurers and the reluctance to cover these medications. And then also, what you said, Dr. Dela Cruz, is also almost like, will we get to the point where the drugs are going to replace the need for the bariatric surgery? But let Dr. Boswell go first.
Yeah, thank you. So, I mean, one of the ways insurance is set up in the US is that we don't tend to stick with the same insurer for a long period of time. We all probably move jobs and you eventually age into Medicare. So insurers, they are thinking about long-term costs, but they're primarily responsible for your short-term costs. They might not see benefits to these drugs 20 years down the line because you're probably not insured by them 20 years on the line. So the incentives there are 100% aligned. Also, I think some of the cost of these drugs, we talked about them being high cost. The cost, though, you hear about in the news, very much overestimated. You hear about a $15,000 list price, actual net price to insurers. They get all these black box discounts, more likely in the range of $3,500 to $5,500 per year. Now, that's a lot of money. And again, we have 40% of the population who could technically be covered, adults, covered by these drugs. So total cost to insurers is really large. And even though the overall economic impact of obesity to society is very high, if we're looking at per adult extra cost per year, it's closer to $2,000. So if I'm obese, I'm likely to have costs that are $2,000 as compared to the average person who is not. So for the insurer, making that short-term trade-off, you can see why it might not seem like the most cost-effective solution for them, especially as they have to cover so many people. And think about these big public insurers like Medicaid and Medicare. That's a huge number of people who would have to be covered for this drug if they were to widely approve it. And that's why we've seen a lot of these limitations. But again, that's partially due to the way things are designed. And I think the physicians probably see a lot more of this in their day-to-day practice of who can and cannot get access, certainly, to these drugs.
Yeah, any comments about that?
I have a question for Emma.
Sure.
So bariatric surgery, for example, and effective therapies for obesity have been shown to potentially be cost effective in terms of quality of life years. But I've
Absolutely.
never seen any data that it's actually cost savings. So if you're an insurance company and you want to save money, do you know of any research or data showing that any treatment for obesity is actually cost savings to a company who's providing the support?
That's a great question. And so what I've seen so far hasn't been covering societal costs. It's been covering these medical costs only. And also, as I said, most of what I've seen recently is to do with these drugs, and the costs aren't being estimated of the cost of the drugs correctly, which makes the whole cost benefit trade-off. But to my knowledge, no. I think a lot of these things, though, are focused on these shorter term costs. If you're talking about like a government, though, like the UK, where they're also considering the other economic benefits, maybe if we were to factor in presenteeism, absenteeism, societal costs, then we could see the cost savings. But no, to my awareness, I have not.
Okay. And Dr. Dela Cruz, did you want to comment at all?
Yeah, it's just, you talked about the meds taking away bariatric surgery. I think for a while, the surgery is here to stay just because it is effective. And in reality, right now, we're operating on 1.5% of potential patients as it is. Patients that are getting obesity treatment, I think, are about 2%, 3% a year. So there is still such a potential backlog of patients and such a huge group of patients that I think that people are going to need different things. And over the last year, I'd say probably 70% of my patients have been on the GLP-1 drugs and come off it for one reason or another. So people are not going to, not everybody's going to take this drug for the rest of their lives. Some people are going to look for other options.
Yeah, and let's talk then about where we are in the evolutionary process of these therapies. Where are we going to something that is more accessible to more people, access, price, etc.? Whoever wants to start.
So I'll just make a quick comment. These drugs, they're remarkable because to think all the pathways that Ernesto showed that drive people to eat is blocked by, a GLP-1 agonist. It's quite extraordinary that everything that we've evolved to be, or if you, I don't want to get into a religious argument, but that we've evolved to be can be blocked by this one medication. And so it's really like, like penicillin was and insulin was. This is a major game changer in terms of health for people. And so the demand for this is going to be incredible. The ability to provide that demand to the population is going to be very, very difficult because it's such a large percentage of the people. And these drugs are not so cheap to make. And there's a lot of places will not be able to afford them. Countries not able to afford these medications.
Yeah. I just want to address this question because a lot of the people in the Q&A box are asking this, and that is whether how these medications can interact with mental health medications, antidepressants, anxiety medications. This seems to be a hot button. Anyone address?
So I'll say that at least I don't know the data across the drugs, but at least for semaglutide, I'm a little more familiar with that. One, we are investigating that. So we're looking at a study, or we're looking at data from some of our earlier studies comparing effects in people who are on an antidepressant versus those who are not on an antidepressant at baseline to see if there's any difference in outcomes. But if the question is more about does the medication affect the action of other psychiatric medications, I would say that there is a small delaying of gastric emptying. So the GLP-1 basically slows down the rate at which your stomach empties its contents, and that can um, affect absorption of other medications to a degree. Now that effect seems to be short-lived, and it seems to be pretty mild, but it's something to be aware of. If you look at whenever if we're going to make a drug available to the public, we need to do a number of drug-drug interaction studies, and they do not show effects of reducing the effect of other orally taken medications. Now, we can't test against every drug that's out there, but broadly, we don't see much of an effect.
Mhm. And Dr. Bernal, Ms. Rahi, you in your presentation had said that these drugs also affect other addictive behaviors such as alcohol abuse, etc. Could you address that? That's an important point. You might be muted.
Yes, there is some data that support that concept, and I see some of the patients not only the addiction to alcohol, but also a lot of my patients come and tell me that they have somewhat lose the enjoyment of eating or food consumption. I don't know if Sam has any comment on that, but so a lot of patients say, I just don't feel like I want to eat more, and I'm not enjoying as much, eating like before.
Yes, that seems to be the buzz of people saying, I've lost interest in food. Is this true? Is this anecdotal?
Yeah, so I
And
think
it-
losing interest in food is not the same as not enjoying food when you eat. And so I've not really heard that as much as they don't enjoy the food, they just as a lost an interest in eating as much as they used to. And I don't think there's any real data that there's increased depression, but maybe Anthony and Brian would know more, increased depression with these medications. But certainly people who lose weight in general become happier and their quality of life improves. And so I think that might offset if it does have some effects on the pleasure of life, because it does reduce the addiction and the pleasure of drugs and alcohol, that it's offset by far by the weight loss.
Yeah, and we've heard a lot of patient-reported anecdotes of changing a food preference. Don't want to eat the sugary foods anymore, and
right.
I think that is a characteristic of GLP-1 based medications that needs more intensive study, and preclinical studies are ongoing there despite its limitations of studying in rodents. But there seems to be something there also with food preference that is then working on the hedonic aspects feeding, and that could be a potential for further innovation when we're talking about further next generation medications. We're working on the hedonic aspects of feeding, not just satiety or appetite per se.
And we'll probably close with that when we get closer to it. But I went ahead and went into the Q&A box just to monitor the many questions coming over. So let's just go right at it. Here's someone who says, I read an article in AARP magazine that said people over the age of 70 should be cautious about taking GLP-1 medications. What do you think? Not for the older population, or not enough science?
Anybody want to stab at it?
So I think older people don't need to lose weight to increase their lifespan. They've already proven that they beat that target, but they do improve their quality of life and physical function dramatically. And so weight loss in older adults is really meant to improve quality of life and physical function. And so in my opinion, there aren't great studies in the older adult population, but I think it should be studied, and this would be a very appropriate therapy for older adults to improve their quality of life.
I'll add two things to that. Oh,
Yeah,
go ahead.
Anthony.
All right, thanks. So one thing I think is perhaps that article was referring to, I didn't see it, but it may be referring to loss of muscle mass. And that's something that is a concern in older adults. So yes, generally weight loss in people who have excess weight does improve your physical function. So whatever muscle you lose, you make up for in better functioning muscle. But that may not always be the case, especially in older folks. The other thing I would add is Brian mentioned a study earlier. It was a cardiovascular outcome study in patients with obesity and cardiovascular disease. So they've had a heart attack, a stroke, or peripheral arterial disease. And many of these folks were over the age of 70. I don't know the percentage off the top of my head, but I think it was at least a quarter of the sample. And the adverse events in that study, or the main outcomes, were heart attack and fatal and non-fatal heart attack and stroke. And it was reduced in the patients who were on the medication and compared to those who are not. So that's one aspect of health, but at least that aspect of health was improved and not harmed.
Mhm. Okay. Here's an interesting question. Do people who have lost weight with the GLP-1 drugs might still need surgery to reduce their quote unquote huge stomachs, is the way this person put it. But there is a method to the question. Is there such a thing as the stomach being super enlarged and because of their obesity?
That one's got you written all over it, Dr. Dela Cruz.
Yes.
No, you can't tell how big someone's stomach is by how big they are. I have seen 500-pound patients with very small stomachs and thin little old ladies with humongous stomachs. So one thing, it's not a size that matters in the stomach. It's not just a sac that holds food. What Dr. Bernal talked about at the beginning of this whole presentation was that there are other mechanisms that are involved in hunger and satiety. And those mechanisms are what make you eat and make you stop eating, not when your stomach gets full. That's a minor mechanism. So there are other more powerful things that are involved. And this is the same discussion I have with my bariatric surgery patients all the time. I have to tell them I'm not a plumber making your plumbing smaller, and that's why you lose weight, but I'm an endocrine surgeon. I change the organ that produces the hormones that makes you hungry and makes you full. So no, you can. It's a question we get all the time, but no.
I'm sure you do. And along these lines, Dr. Dela Cruz, because we've talked about this before, and is that the new surgeries, the new types of surgeries for obesity are perhaps much more improved than what we used to talk about 20 years ago when the inception of these. Could you do a quick explainer for that? Because there are a lot of people on the chat asking.
Yeah, I'll try to be real quick. The surgeries aren't a huge difference from what they were 15, 20 years ago, but they are definitely more standardized. And the outcomes are better known. We have national databases that show that getting even a gastric bypass, one of our more aggressive surgeries, has a lower mortality rate, or you have a lower chance of dying than getting your gallbladder taken out. And so people don't realize when they look, bariatric surgery is being done so often and at good centers with such low complications that it's much better than going to get your gallbladder taken out, going to get your knee operated on, going to get, your colon resection. All those things have higher complication rates, but people don't realize it. But it's just what happens when docs do the same thing over and over again. So it is much safer than people think. And there are definitely things available, and there's a lot of exciting stuff going on, in the bariatric endoscopy field as well, doing some things through the mouth instead of going through the belly, to try to help patients to lose weight. So that's going to keep growing also in the future too.
And if we could then, transition to where are we headed with all of these new therapies and these new medications? How quickly are they being developed by the scientists and in the lab that pretty soon the Monjaras and the others that we keep talking about are going to be yesterday's news? Could we all address this?
Yeah, well, why don't I start first, as I'm on the discovery research side. So first I'll say the terzepatides and semaglutides aren't going anywhere. They're here to stay, but we're already across the entire industry, from academia to biotech to large pharma, working diligently and fast on what's those next generation medications there. And there's a lot of components that we're looking at there, you'd say, across the industry on whole, from what I say is the race to the bottom. Can you get the most efficacious drug to lower body weight? You mentioned, and Ernesto showed the slide, tirzepatide reducing body weight by 22.5% in the phase 3 trials. The next generations from there of retatrutide, the triple agonist, 24% body weight lowering, but at half the time. So that's why I say the race to the bottom. There's a lot of work there, but not all patients are going to need 25, 30, 35% body weight loss. So then there's also treat to target programs to look at. Can you use different dosage strengths to reach a certain weight loss? But it's also, I say, is going beyond just weight loss. And that's what we've talked about in this call here, that it's more about improving health. And so those are aspects of quality of weight loss that Anthony started to allude to, about preserving some lean mass during weight loss. And it's more about functionality and metabolic functionality of that muscle mass. To also making medications that are more scalable, things that are more cost effective, things that can be produced in high quantity so you can reach a larger volume of patients. And in particular, you'd say maybe those are provide a little bit more convenience to the patient. So oral options instead of injectable options, or very low frequency injectables. I would say right now we're at really the precipice, or maybe even just the start of that trajectory upwards of additional research across the entire industry back into obesity and obesity medications. And so I look forward, and I'm proud to be a part of that journey. I look forward to where we're going to be a year from now, 3 years from now, 5 years from now.
And just to add on a tiny bit to that, I think one of the other benefits to this increased competition in these new medications, like you alluded to, is going to be lower prices. And we might not see them in the list price, but these companies are competing behind the scenes to get better coverage on insurance. Well, that could increase access for patients, could lower costs in the long run. It's good for all involved.
Yeah. And since we have the representatives here from Big Pharma, I mean, who wants to make a projection? How close are we to this? Exactly what Emma was just saying: lowering the cost, greater accessibility, more patients being able to take this drug. Are we a couple years away? Are we 10 years away? Where are we, given the fact that we have an epidemic of obesity in the United States?
I am really loath to make an economic prediction.
Attack it from the
it's hard
science
to.
standpoint.
I'm sorry.
I said attack it from the science standpoint. How
Yeah.
much is this being studied in the lab that we're like ready to make a turn?
Yeah, so I was looking at the pipeline, just a broad obesity pipeline, and I'm just going to guesstimate there are about a dozen drugs in phase 3 right now. I mean, the last stage before a drug can be approved. Another couple in phase 2 where we figure out how much drug is effective and safe before we start to test it on a larger scale. And by we, I'm talking about the industry in general, not necessarily my company. And then if you go further back and one step beyond where Brian, I think, does his work, the first in human studies, there are not countless, there are several dozen.
Yeah, absolutely. And there's you say it's the arms race right now and stocking up on anti-obesity medications from late preclinical development, early clinical development. So it is really expanding and booming there. So the science has pushed forward and anticipating, and also you say hoping, but also driving that there is going to need more options, increase the toolbox that providers and patients have at their whim in the future. But these things all have to happen in parallel as well. Improved access, and I know we've talked about it. Improved access has to come here, and improved insurance coverage. I mean, just the fact that with Medicare, it's prohibited by law to have an anti-obesity medication. If that changes itself, how many more patients could get medications, et cetera. So all of these things need to be happening together, not in isolation, but they are moving. To be honest, year over year, seeing the improvement of access, more players getting into the market, and a highly commoditized market will actually help with effective cost, et cetera, and all of this. So we're all happening. We're all doing this together.
No question. And Dr. Burnell, Ms. Rahi, if you could tell us, how is the University of Miami and U Health positioned specifically in this field, and how clinical trials accessible to us in our own backyard for the hundreds of people that are on tonight? Could you address that?
Yes, we have several faculty involved in clinical trials using the current medications available in determining different uses. And also, we are currently partnering with pulmonary to develop a clinic that will be focusing on obesity and sleep apnea, and probably designing studies to understand how some of these medications can affect the responses and the severity of sleep apnea, especially knowing the comments that were mentioned before in terms of sarcopenia, decreased muscle mass, and how that can maybe affect the efficiency or the efficacy of these therapies. And I wanted to come back about some of the details that were mentioned as to where we're going in terms of developing new medications. But and I focusing on asking Anthony and Brian it is clear there are some patients that respond better to some of these medications. And my question to you is, in addition to developing, new agents, is how we can really determine what are the patients that will respond more to one or to another, and in terms of maybe perhaps pharmacogenetics. And so what is the landscape on that area?
Yeah, absolutely. I mean, across all of the clinical trials, we see a pretty a normal distribution of patients that we'll call non-responders or low responders, is low percentage to also high responders. But across all of the medications, it's the same bell-shaped curve. It just kind of shifts to the right with an increased efficacy if we're just looking at weight loss. But studying the non-responders is a very important aspect of discovery research, because it's also maybe it uncovers a physiological pathway that is perturbed in obesity. And so you could start to segment individuals based on types of obesity. And then also just thinking those patients that are unresponsive to GLP-1s and depending how you define non-responsive, that's maybe 5 or 10% or so of patients. Those individuals need something. They need an effective treatment. So what's non-GLP-1 based medicines out there that may be effective? And there's a bevy of hormones that are being looked at, amylin being one of those that is showing pretty remarkable clinical efficacy. But it's, in our clinical trials across the industry, I think we need to do a better job at what I say is carving out the whole buffalo, in terms of we need to do stronger genetic analysis of patients. We need to do better phenotypic analyses of patients so that we can understand after the fact why those patients are not responding, so we can go back into the lab and cook up something that could be effective in them.
We're getting ready to wrap up, but there's a question that came across that asks this: can these drugs affect the kidneys or liver or other organs long term? And could it have any negative effects on erectile dysfunction, complications on ED? Anybody?
Well, I can speak to the benefits that we're seeing on kidney health and liver health with these medications. GLP-1 based medicines, multiple of them have been tested in fatty liver disease, now called MASH, and they're showing signs of effectiveness. How effective are they at fibrosis needs to be substantiated and proven, but they are reducing hepatic or liver fat content, which is improving liver health there, and they may have a benefit in liver disease. They need, again, to be proven in phase 3 trials. in terms of chronic kidney disease and renal impairment, there is proven benefit now of GLP-1s in renal impairment in type 2 diabetic patients. But again, if we're talking about obese individuals, which there are a propensity of or a predisposition to chronic kidney disease, have to better understand how GLP-1s work in that patient group. Erectile dysfunction, I don't know any data there, so I'll let someone else comment.
If no one is going to take that one on, let's just give a quick 1 minute around with a wrap up from each of you. Dr. Dela Cruz, if you'd like to start and just basically say, hey, this is where we're at, this is the 21st century, and this is how we're attacking the obesity epidemic. And then we'll go around the room.
Well, it's fun to be involved in a panel like this where you can work with colleagues that work on it from all the different sides. And I have to thank the guys who work in the pharmaceutical industry, because without you guys, we wouldn't be making progress, even with all the bad rap that people get on, all over the place. So thank you for what you're doing and for the curiosity to keep finding better drugs for our patients. So, from my standpoint, we offer the bariatric surgery, we offer the bariatric endoscopic stuff. We in our office also does offer medical therapy for obese patients as well. So it's part of the whole process, and we work with all these other groups that you see here that are at to try to incorporate the total health of the patient, so that we can make people healthier. Not any one of us is a plastic surgeon. We don't really care that much what you look like and how you look in a bikini. What we want is to have a healthier patient that can do well in the long term and be around for years.
And maybe one or two more of you, if you have some inspiring words for the future for us to share.
Sorry, I just want to mention that this is an exciting time to be an endocrinologist, because we have now tools and alternatives that we didn't have before. Before, treating diabetes and obesity was very frustrating, because, we had only insulin and some limited, armamentarium of medication. So I think that this is an exciting time for us, because we can offer different options to patients that are in major need.
That's the perfect last word. None of us could have said it better. It's time to wrap it up, everyone. We cannot thank you enough for the privilege of your time. It has been eye-opening. It gives us inspiration for the future. We thank you all for your time, the privilege of your time. We thank the audience for being interactive. I got a few questions in there, folks. We did our best. It's just a huge topic. So good night to all of you, but let's put up the screen right there to show you how, if you're interested in exploring medical weight loss options, please call the anti-obesity helpline at 786-654-4829. Before you lose that screen, maybe you want to take a picture right off your laptop and keep that so that you can be in contact with us. Remember that our specialists are here to support your journey toward a healthier lifestyle. Not just a pill or an injection is going to do it. You have to live a healthier life, and we're here to help. So please complete the survey at the end, and we will see you again on another talk. We wish you all well. Have a great night, and everyone stay safe out there. Thanks so much for being here.
Good night.
Night.
Good night.